Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Novo Nordisk AS.
This program is presented by Medscape Education Global.
Hello, I'm Helen Colquhoun, Professor of Medical Informatics and Epidemiology from the University of Edinburgh in Scotland. Welcome to this program entitled Interdisciplinary Dialogue, a Cardiologist's Guide to Evidence-Based Obesity Care. And joining me today, I'm delighted to have John Deanfield, who's Professor of Cardiology from University College London, and Nicholas Marks, Professor of Medicine and Cardiology, Department of Internal Medicine at the University Hospital Aachen in Germany. So, Nico and John, I don't need to, of course, say to you two that obesity is a key driver of this triad that you must see every day in the cardiology clinic of cardiovascular disease, very often accompanied with reduced kidney function and diabetes or dysglycemia. And of course, for this terrible triad, we are now entering an exciting new era of anti-obesity medications. And I think that we have known for some time that GLP-1 receptor agonists reduce cardiovascular disease among people with diabetes, where they have been prescribed now for several years. But the effects overall in diabetes and without were summarized very nicely in this meta-analysis that came out just a few weeks ago in the Lancet Diabetes and Endocrinology journal, where they summarize that from the diabetes trials, there is a net 13% reduction in cardiovascular disease with this class of drugs. But also, they added in the more recent data from the SELECT trial of semaglutide 2.4 milligrams weekly versus placebo, in which there was a reduction of 20% in MACE in that trial. And that trial, of course, was conducted in people with obesity or overweight and prior cardiovascular disease, but without diabetes. Now, John, I know you were very closely involved with the trial. So do you want to just tell us a little bit more about the range of beneficial effects in the trial?
Yes, Helen, thank you. So this was, as you say, a very important trial because it took these drugs out of the field of being diabetes medicines or even weight loss medicines, but actually demonstrating that they could reduce clinical complications of cardiovascular disease, even in the absence of diabetes. So what we did in SELECT was to randomize people who were overweight or obese, and I emphasize that these were people whose BMI was only 27 or greater. Many, many patients like this are seen in cardiology practice. And we randomized them to an escalating dose of semaglutide up to 2.4 milligrams subcutaneously once weekly versus placebo. And we studied them for nearly 5 years in this trial. There were more than 17,000 patients. And as you point out, the key information was that they got improvement in hard outcomes of cardiovascular morbidity and mortality, stroke, heart attack, and the like. MACE was reduced by 20%. Now, we also saw benefits in other cardiovascular manifestations that we previously might have underestimated in such patients, like heart failure, for example. Heart failure is tightly related to the presentation of these patients with obesity and cardiovascular disease. And increasingly, we see heart failure with preserved ejection fraction in such patients. Those patients got equal benefit in the SELECT trial to the patients who did not have heart failure. Importantly, for the clinical cardiologist, there's been some concern in the past that their patients who had heart failure with reduced ejection fraction would not benefit, but we saw equal benefit in those patients as well. So reassuringly for the clinicians starting these drugs, It didn't matter what your weight was at entry or whether you had heart failure with preserved ejection fraction or reduced ejection fraction. All of those patients got the benefit.
Yes, and interestingly, we also found in the trial that there was a beneficial effect on kidney endpoints. So we reported a reduction of 22%, in fact, in the kidney composite endpoint in the trial. And we also saw, looking directly at EGFR and albuminuria, substantial benefits. For example, in those with an EGFR below 60 at baseline, there was a net 2.2 units of EGFR benefit over the trial period up to 104 weeks, the pre-specified analysis time. And for albuminuria, there was actually about a 30% reduction in albuminuria in those who came into the trial with micro or macro albuminuria. So very nice to see those data of effects on kidney outcomes as well. And then, of course, we also showed, which was quite important to demonstrate, that there was at least the same effect on MACE in people coming into the trial with reduced kidney function or with albuminuria as it was in the trial overall. So really important data there for kidney disease as well. We uh, see these benefits. We also saw, we won't discuss it much now in the interest of time, but we did also see beneficial effect of reducing progression to diabetes. So, Nico and John, I'd like to have your thoughts about what you think is driving these beneficial effects. Do you think it's all the weight reduction?
Well, that, Helen, is an absolutely key question. Traditionally, we've associated the damaging effects as being related to the amount of weight, but that was not the case in the SELECT trial. What we saw in SELECT was the cardiovascular benefits were not related to the amount of weight that the patients lost in the trial, or very loosely related. And what that means for the practicing clinician is that we can recruit people at different levels of adiposity. It didn't matter what your weight was at the entry in terms of benefit, but also get cardiovascular benefit even in the patients who are not losing substantial amount of weight. It also begs the question of what is it that is responsible for that benefit? And it looks like these drugs are having underlying effects on the biology of many of the diseases we see in our patients, and not just reducing their weight and producing benefits in that way.
Yes, and I think we also saw some interesting effects in some other markers, such as CRP for, which is, as you know, a marker of total body fat mass, but also a marker of inflammation. Do you have any particular thoughts or comments about that?
Well, I think maybe I can chip in here. Indeed, we've seen a robust and very pronounced reduction in hsCRP, which is an indicator of subclinical inflammation. Subclinical inflammation is present in patients with obesity and overweight and is a major driver for cardiovascular disease. And based on what John just said, other mechanisms seem to play a role here. And the anti-inflammatory properties, I think, are a good candidate, is a good candidate here to explain some of the results.
Yeah.
So, Helen, that's what Nico said is absolutely right. And it may well be that the common biology of many of the diseases we see in our patients actually can be targeted by these drugs. And that's why we're starting to see benefit, not just for individual diseases like cardiovascular disease, but also for kidney disease, as you've already shown. We see it now for neurological diseases. We see it for liver disease. All of these diseases share that common inflammatory biology that Nico was talking about. So I think that's very exciting for us because targeting that common biology may give us leverage gain across multiple problems that we see in our patients.
Yes, I think it's really interesting. So, tell us a little bit more about other drugs in this class, in particular, the combination of GLP-1 receptor agonism with GIP receptor agonism. Tell us a little bit. We know that tirzepatide is now licensed for obesity treatment. Where is it with respect to evidence with regard to cardiovascular disease reduction?
Nico, I don't know if you want to take that one.
Yeah, I can take that one. So first of all, it's important to mention that tirzepatide is a dual agonist. So GLP-1 receptor and GIP receptor. And so you get basically the best of two worlds here because the two incretin hormones have differential effects. And indeed, if you look at the weight loss data from tirzepatide trials, there's a more robust weight reduction compared to GLP-1 receptor agonists. And the first cardiovascular data we've seen now come from the Summit trial, which is a phase 3 clinical trial in patients with heart failure, HFpEF, and obesity. And here the outcome was improvement of quality of life as assessed by KCCQ, and tirzepatide led compared to placebo to a very robust reduction. In addition to that, very robust weight reduction and also reduction in hsCRP, what we discussed before, but also reduction in blood pressure, for example. So a very, very an effect that affected quality of life in patients with heart failure. And given the increasing incidence of obesity and HFpEF in particular, for what we didn't have real treatments until the SGLT2 inhibitors came up, this is, I think, something where cardiologists need to familiarize themselves with usage of these agents. So the word anti-obesity medication may shift to cardiovascular reducing medications at a certain point.
Yeah, I mean, I think that's the interesting point is to start seeing this class of agents as beyond just management of obesity. Um, so we've talked a little bit about the evidence supporting the cardiovascular effects. I'd like to turn now more to individual clinical decision making and ask you, Nico, and also John, what type of patient in the cardiology clinic would you now really consider for starting on a GLP-1 receptor agonist? With what level of BMI, at what level of CVD risk would you initiate treatment?
Well, let me talk about a patient that I've just seen, which is a gentleman, let's say, end of his 50s with coronary artery disease. He had a myocardial infarction 2 years ago, has normal ejection fraction, diagnosis of hypertension, dyslipidemia, no diabetes, and a BMI of 32. Of course, we treat hypertension, we get the lipids down, we give aspirin, but since he doesn't have diabetes, there's nothing else we could do so far. But now, based on the data, he would be a candidate with BMI of 32 for example, a GLP-1 receptor agonist based on the SELECT data that John just presented, because he would fulfill the inclusion criteria and certainly be a candidate for such an agent. And I think that enriches our armamentarium how to reduce cardiovascular risk in addition to what we had so far.
Yes, that is interesting, and it really is great to have this additional tool in the toolkit for sure. Um, I think, given that this class of agents might be relatively new for cardiologists prescribing, can you give a little bit of practical guidance on how you found the best way to initiate treatment, dose escalation, and so on, so as to maintain adherence and persistence with the medication?
Yeah, I think this is very important. We need to familiarize ourselves as cardiologists with these agents, and we have a long-standing experience in diabetes, for example. It's important to explain to the patient the mode of action, to explain that you need to start at a very low dose and a slow up titration, because gastrointestinal symptoms, nausea, for example, is frequent, but we explain to the patient that this is temporary. And we give clear advice, for example, small meals, stop eating before feeling full, not too spicy, that often helps. And of course, some other things you need to consider if you're giving it to a patient with diabetes, you're lowering blood glucose. And if the patient is already on sulfonylurea or insulin, you need to stop it or reduce the dose. GLP-1 receptor agonists, for example, itself do not lead to hypoglycemia, but the concomitant treatment with one of these two agents might lead to hypos. And finally, we need to explain to the patient that uptitration is slow. And concerning controls of lab values, it's important to know that these agents increase lipase, for example, pancreatic enzymes up to 20%. But as long as the patient doesn't have symptoms, there's no need to do additional diagnosis, because this is only a phenomenon that is not associated to pancreatitis. And I think this is the part where cardiologists need to learn about it. And then in our department, we used it for years in patients with diabetes. And the patients come back and initially explain they had not the GI symptoms, but over time that disappeared. And that's important for them.
So Helen and Nico's talked about the importance of slow up titration of these drugs, very important for those common GI side effects. Importantly for cardiologists, it's reassuring that the serious side effects that we're all concerned about, pancreatitis, for example, have been very uncommon in clinical practice now. And so they're remarkably safe from that point of view. The biggest problem, as well as the nausea and the GI side effects, has been the fact that you do tend to lose muscle mass when you take these drugs. So at the same time as you need to talk to your patients about the importance of up titration slowly and the anticipating gastric side effects, we have to tell them that they need to be doing exercise regimes that allow them to minimize weight loss due to muscle loss. I think that's going to be a very important part of the treatment with these drugs.
Very important point, yeah.
Yeah, I mean, I think there's still some question about whether or not all of that loss of muscle mass is necessarily, a real reduction in muscle mass. It may also partly reflect reduced fat as well. I think, but nonetheless, I agree that yes, very much so, ensuring that patients maintain and even better increase physical activity is really key. I'm interested as well in your thoughts about how you think having this new class of agents for managing patients in the cardiology clinic, how that now uh, relates to how do you have any different physician-patient communication strategy here? Um, uh, do you use just physical leaflets? How do you approach ensuring a good communication between physician and patient with regard to this class of drugs?
Well, we as said, we take you need time to explain to the patient what to expect and what the side effects are and what the benefit is. And what we do, we either try to see the patient again in our outpatient clinic to see how he's doing, how if side effects develop, how weight is developing. But in addition to that, I think it's crucial to talk to the GP that's taking care of the patient in order to make sure that treatment is continued and that everybody's aware of this drug that is so far rarely prescribed by cardiologists and more often by endocrinologists.
I think it's really interesting that it's remarkable how happy people are when they come back to your clinic. It's a very gratifying experience for cardiologists. We're used to the hard sell of treating people's LDL cholesterol with statins and persuading them to take their medications. People come back here with a visible benefit that they see themselves, and they're incredibly motivated to continue these therapies. So it has been really gratifying to treat patients with GLP-1 receptor agonists who are overweight or obese, because the compliance and the willingness to change their lifestyles once they start to feel better as a result of weight loss has been remarkable.
I want to ask you, you've talked about initiating patients on treatment and maintaining patients on treatment. The other big question is, when should treatment be stopped? Do patients need to stay on a GLP-1 receptor agonist indefinitely? What do the data show, and what does your clinical practice tell you?
Well, that's a really important question, both for the individual patients, but also for the prescribing of the community. We know from a clinical trial that if you discontinue these drugs abruptly and don't change your lifestyle, you will put the weight back on in a large proportion. Now, that's not really surprising because these drugs don't make you lose weight. They make you change your eating behavior largely. And so if you go back to your previous behavior, you're likely to put the weight back on. It's very similar to cholesterol, to blood pressure treatment. If you stop the drugs, those two risk factors go back up. But actually, what we're hoping to achieve with these drugs in many people is a realization of how well you can be at a lower weight. And as part of the treatment regime, we talk to people about changing their lifestyles over that period of time when they're on the drugs, so that when they come off, they have a better lifestyle and have the opportunity and the motivation to maintain a lower weight. In the future, we're going to have to work out how many people need to stay on these drugs long term, whether we can set weight thresholds for other people against which we want to keep them a level they need to stay below, or even microdosing of these drugs may be important in the future to get some of the benefits and maintain a lower weight. But it is likely that there will be different ways of approaching different patients.
Yes, I mean that's the general issue, I guess, that if somebody achieves their target weight on the drug, would you then step back a little, or would you maintain them on the same 2.4 milligram dose? And I think there's probably going to be a lot of inter-individual variation in that, and it's going to be a matter of trial and error, maybe cutting back the dose. But if somebody's weight starts creeping up, then go back to the higher dose if they're tolerating it well. So, yes, I think those are really important questions. And then I guess I think the other issue is how this relates to how we organize care for people at high cardiovascular risk who are also obese. Because traditionally, certainly in our health service, John, we've had weight management services operating in parallel, shall we say, to the clinics. And increasingly, I think we're going to see much greater crosstalk and team management here. I just wonder, Nico, if you could comment a little on how that's happening in your locale.
Yeah, actually, I think that's a little frustrating because we're just trying to build this up. There's no structure so far, and but I think we need, diabetes is a good example. Some years ago, we started to do clinics for patients or people with diabetes and cardiovascular disease. And I think in the same way, we started now to do clinics for patients with chronic kidney disease and cardiovascular disease. And the next step, I think, and this is important based on the fact that we have therapies now, we need to build special clinics for these patients. But I have to admit, in Germany, this is rarely done, and we are just about to start this.
I'm much more positive than the idea that these all have to be done in specialist weight loss clinics. I think what we're going to see as cardiologists become familiar and confident with the use of these drugs, the ability to achieve substantial benefits for the patients in the normal cardiac clinic in the way that we've been talking about here today. So a substantial weight loss can be achieved safely and sustainably by good conversations, by sensible changes in lifestyle, increases in physical activity, and the like. So I think we are going to get away from this idea that we have to start people off in specialist weight loss clinics before we can then start these drugs, because that's clearly not going to work in terms of the ratio between the places there are for those specialist services and the large numbers of people who are going to benefit from these agents in terms of their disease management.
John, I fully agree. I think it's on us as cardiologists to implement therapy, and there's still room for improvement because we have silos, obesity clinics and cardiovascular, and they need to talk to each other. That's what I meant to say. But I fully agree. It's on us to implement therapy.
Okay, well, we're just going to wrap up here, and I'll just summarize really, I think, what I understand from our conversation today as some of the key points. First of all, that it's wonderful that we now have unequivocal evidence of cardiovascular benefit from the SELECT trial of GLP-1 receptor agonists, even in the absence of diabetes, in the patient population who had prior cardiovascular disease and who were overweight or obese. With a 20% reduction. I think that's the key point. We already knew that GLP-1 receptor agonists reduce cardiovascular disease in the context of diabetes, but now we see that even in the absence of diabetes, these drugs have important effects in the cardiovascular system and indeed also the kidney. And of course, we had data, we didn't discuss this much today, but on prevention of progression to diabetes as well. I think we also have benefits on heart failure. And I guess an interesting point that we need to really unravel for the future is that we certainly can't fully explain the effects by the weight change difference in the trials alone. And we note other potentially beneficial effects, such as changes in inflammatory markers, that may be contributing to some of the cardiovascular benefit. So I think we should begin to see GLP-1 receptor agonists not just as obesity medications, but as cardiovascular drugs. And they're part of the key toolkit for people who have CVD and have obesity. And we also heard from Nico and John about some really sensible practical advice on how to initiate gradually, let the patient get used to the feeling of fullness, making sure that we have good advice on eating smaller meals, not eating to fullness, not eating late at night, for example, avoiding spicy foods, and so on. And then keeping the dose titrated according to the tolerability for each individual patient. So I think that's probably the key points, and we'll wrap up there. And I just wanted to thank you both again for your time today and for your willingness to have this really good discussion.
This program was presented by Medscape Education Global.